Some diagnostic tips. We published a sinus elevation difficulty score that can help you in defining the complexity of the case. I will show you now which are the factors. We have a kind of checklist. This is a checklist with some patient-related factors, with some CBCT factor that you can really appreciate on a CBCT. Some other factors related, are you right-handed or are you left-handed? Can change the difficulty of the case. Usually right-handed, they have more difficult to leave the sinus on the left side. Left-side-handed surgeon, they have more difficult to raise the sinus on the right side. So there is a checklist, and this checklist is not only for the novice, is even for the experienced ones that are able to define the complexity of the case and schedule the patient for a longer time. If I have two complex sinuses, I might do one sinus and the other sinus because I don't want to keep the patient under sedation for more than 3 hours. A normal sinus, to give you an idea, when you learn the procedure, is 35, 45 from start to finish. Let's say 1 hour. A difficulty sinus could be even 1 hour and 1 hour and 30 minutes. So you have to schedule the patient, even if you are very experienced, in a different way. Do the difficulty case early in the morning and not do the difficulty case late at night. So this allows you to understand in which section you are. You are green, orange, or red. We do a lot of live surgeries. Do you think that I pick up the red cases during the live surgery? No, I pick up the green cases, and I say to the student, because it's more didactic. It's not only more didactic, because the red cases, you can have a lot of complication, intra-op complication, are more difficult to be dealt. And so, immediately, I understand and I classify the patient according to the difficulty score that has some factor. I immediately look at the face of the patient and I exclude some patients that are more problematic. Which are the patients who are more problematic, for example? The one who have the very thick cheeks, the one who have a transverse place, square faces, small opening, and I pick up for sinus surgery, if I am a beginner, long face, normal face, and I exclude within this group immediately, and I don't even look at the CAT scan, if they had the possibility to choose the green case, some of your faces, only by looking at your face. Because I know that long face, they have a straight wall, and the zygomatic process is more up higher. Square face, the zygomatic process are closer to the ridge. The zygomatic cloud and the walls of the sinus are thicker. And thicker wall, zygomatic process in the way of the sinus are more difficult than thin bone, flat wall that can be surgically done in a much easier way. You attend a course, nobody speaks about this. You are a novice. I've seen that some of you haven't done any kind of sinus lift, so they have to think about, like in endo, I'm doing the root canal on a central incisor, or I'm doing a root canal of the second molar with calcified canal on a patient that is not opening very wide, with a big tongue, with a super big, thick cheek, with some tension that is not nice to you. It's a very difficult root canal. And so even in sinus lift, you have to start from the easy one. And the easy one are the ones who have kind of face characteristics. And with the face characteristic, there are some other characteristics like the thickness of the bony wall, the presence of the septa, the presence of the artery, the presence of the mucosal cyst, the presence of fenestration, some feature that you can see on a CAT scan. And every single feature has a score. You add all the scores, you ended up with easy, medium, difficult. On top of that, you are right-handed and you have to do a left sinus. Most of the time, I switch to the left of the patient. I'm working with the right hand, but I address the sinus in a specific moment of the surgery from the left sinus, because from the left part of the patient, because I don't see very well if I'm right-handed. I can provide you all with this publication. It's like a checklist. You mark and you don't miss very, very important points. This is not submitted. It's already accepted. So we have all these publications. Radiological finding of dispersed graft or transient swelling. To let you understand a little bit about this publication, Friedland is a maxillofacial radiologist from Harvard. Felisati and Saibene are ENT. The very difficult Indian name is an ENT guy. So they all collaborated to this publication. Why? Because you need to have a knowledge of sinus physiology, radiology, and basic science to understand this situation. Because if I'm showing you this situation, you might ask yourself, what is this? Is graft in the sinus? Is thickening on the membrane and the graft particles are inside an inflamed tissue? Is it a sinusitis? You see this case. Is it a sinusitis? You cannot tell that, because if you want to do surgery on a predictable base, you should be thinking like a medical doctor. To have a disease, you should have symptoms, signs, radiological signs, blood test signs. So, to have a disease, you should have all these factors that allows you to make a diagnosis. It's important to understand that the patient is not a CBCT. So if you see this situation, but you know that you started from an healthy sinus, at 2 months you have this problem, 99% of the doctor, because I know this paper has been around 3 years. Why? Because all the referees, they ask more explanation. Why? Because they said sinusitis, the less knowledgeable, no, you have a sinusitis here. Big mistake, because the patient is not a CBCT. This is a sinus opacification, full stop, not a sinusitis. Sinusitis, symptoms and signs. Is it graft inside the sinus, or is it swelling on the membrane? No one knowledgeable radiologist can tell you this. Let's see this. First of all, why this patient had a CBCT taken at 2 months without symptoms. Why? Because the patient was in Rimini at the seaside, and the bridge got de-cemented. He went to a normal dentist that has a CBCT, and the normal dentist did a CBCT to check our work. So, from the ethical point of view, you should not do a CBCT to evaluate the work of somebody else unless that patient has symptoms and signs, and the CBCT most probably will change the diagnosis of that patient. So your CBCT should have a justification. The dentists mainly do CBCT because let's check, like when they do the endo treatment, to check the sinus lift after the elevation, or to check somebody else's work, just to see is not the poor patient, and the CBCT is not justified. There are world guidelines that tells you that you should reduce the level of the doses for the patient. So, to make the longer story short, the poor patient was very scared. He came up to Milano the same day. We evaluated the patients with an ENT through the nose. The patient has no symptoms, no sign of infection. only sinus opacification. Only sinus opacification. We convince the poor patient to wait and see and monitor the patient, that most probably we can have resolution of the opacification. We need to wait a little bit longer. But if the patient trusts the doctor in Rimini, and most probably the doctor in Rimini will remove everything. And the poor patient will have an additional surgery that is not needed. Why? Lack of knowledge in sinus physiology, lack of knowledge in medical thinking, that the patient is not a CBCT, but the patient is a human being, and when he has a disease, he has symptom and sign. We haven't done anything. 8 months later, this is the situation. The ENT said, give her some nasal spray. I said, no, don't give her anything, because if I give a nasal spray and I write in the paper that I gave a nasal spray, the referees might say, yes, because you gave nasal spray. No, we didn't give any nasal spray. 10 months from the surgery, 72 months from the surgery. Now, upon resolution, we can understand that this one was not grafted inside the sinus, this one was grafted inside an inflamed membrane. Because you see that the shape and the morphology of this graft material is the morphology of this graft material. We have 7 cases in our paper. I don't show all the cases because they are just the same. So the clinical message here, first of all, the patient is not a CBCT. It's like in normal dentistry. Doctor, I cannot chew on this tooth. The doctor doesn't even look at the patient. Do a radiograph. He shows the radiograph of the monitor of the patient. There is nothing. No, everything is fine. Root canal perfect, perfect. But I cannot chew, but it's perfect. Okay. The patient goes out, and most probably he will ask for a second opinion, and the second opinion says, okay, the tooth can have a fracture that is not visible, can have some other problem, cracked tooth syndrome, problem due to occlusion, internal resorption, other pathologies that you cannot see on a CAT scan. You cannot see on a smaller radiograph. The patient has transverse plane and thick bone. If the patient has a thick bone, radiographed, you don't see periapical lesions. Why? Because the thickness of the mandibular bone prevents the detection of lesions around the apices. And you have to have a large lesion that erodes the bony walls to have the possibility to see that lesion. So it's always a lack of knowledge. But the more complex is the case, the more complex is the solution of the case. So I truly believe that this paper will open the mind of many implantologists around the world and understand that a sinus opacification without symptoms is not something that immediately calls for another surgery. So the clinical approach will be wait and monitor the patient, tell the patient to call you 7 days a week, 24 hours a day, if she develops or he develops some signs of infection or some symptoms. You will be always ready to remove everything. We knew that for many, many years, because after the sinus lift, you can have a zone of opacification due to mucus accumulation, because when you lift the sinus, there is a physiological phenomenon called ciliostasis. The cilia, they stop beating, and you have accumulation of mucus because still the middle layer is producing mucus. There is another issue. Why we prescribe nasal spray with cortisone of antihistaminics? To decrease the production of mucus, to decrease the inflammation of the ostium, in order to prevent future problems. So every time you do a sinus lift, you can have some kind of opacification inside the sinus that is due to, for example, mucus, small perforation and some saline gets inside the sinus, but without symptom and sign, just wait. This problem can be even in transcrestal approach, crestal approach, published by Kirinen, Marke Kirinen from Leuven, showing you the same. Look at the opacification after a crestal approach. You wait and everything will be solved. This group from Japan show you the same exact situation. Then type 1, type 2 and type 3, you can have always this kind of opacification after the sinus lift that can be different from one patient to the other. Some more, some less, or some none. We are different. But please, from Monday, you should think like a medical doctor to have a disease, symptom, sign, and radiological findings are an adjunctive factor for the final diagnosis. And please wait and monitor. You will avoid a lot of unnecessary additional surgery due to lack of knowledge of implantologists. When you have this, you don't wait and monitor. You have to do something. And you will be able to do a functional endoscopic sinus surgery, opening a new ostium, but you should send the patient to a knowledgeable ENT, and you should have the knowledge to evaluate the work of an ENT. Because like us, the ENT, they have a learning curve. If they do not have experience, they can enlarge the major ostium without solving the problem. It's very important to check and to give you some it's only one factor that you have to look when you see a CAT scan. I see this opening, I know immediately that is not the sinus opening. I saw that opening, and immediately I know that is not the sinus opening. Why? The natural sinus, or that it drains the mucus 1.5 liters on average every day. Why? Because it's larger, and because there is not the uncinate process. The uncinate process is this one. The uncinate process guides you to the natural ostium. This is a case of an ENT mistake that is done, an enlargement to the accessory ostium, and he left intact the natural ostium. And the patient, you can do multiple functional endoscopic sinus surgery, but you are always opening the wrong one. Can you go up and say that there is some patient who is always... So it's even in the literature, the missed ostium sequence, because even the ENT, they can have difficulty noses inside, and they can do a mistake, enlarging the wrong ostium. So, this is not the ostium. This is the ostium. And if you have a pathology, you should open here, not enlarge this one. And if you enlarge here, and you leave the natural ostium closed, you don't solve the problem. Very few dentists, implantology, they know this. Because if you have to team up with somebody that can help you, even if you are not doing the procedure, you should be at least knowledgeable, and you should be aware of the mistakes that the patient can undergo when referred to a non-knowledgeable ENT. As I said, I'm doing the surgical phase. I have my prosthodontist, but at the end of the work, at the end provisional, I want to have some checks that are done by myself, because even if I'm not doing the prosthesis, I want to check the patient before the final restoration. Why? Because I am in charge of this office, I am in charge of the department. If you are my patient and I send to him to solve the problem, and he's not able to solve the problem, you, patient, always come to me and you say to me, doctor, I still have a problem. And you refer me to this very knowledgeable guy. Why is not helping me? Why is not solving me? And you had at least to have the possibility to check the work of somebody like the ENT. So when you send a patient to an ENT and you have the resolution of the problem, ask for a CAT scan. Don't ask or send the CAT scan to me, and we will check with our ENT if he made a mistake of opening. This guy has done 2 functional endoscopic sinus surgery, always symptom and sign of infection, because you can enlarge forever the wrong spot and the patient will never be healthy again. So the conclusion of this part is very easy and straightforward. Start from a ostium that is open. If you start from an ostium that is open, very easy, straightforward. Don't think that the patient is a CBCT. If you have graft dispersed inside the sinus and you are lucky that some particles are going through the nose because you have done a sterile procedure during a graft placement. When I teach very experienced doctors, and you explain that, and I'm showing that cases that 100% of the doctors, I remove everything because they think that the patient is a CBCT. And I said, in your career, you had patients that are telling you, listen, I did a sinus lift, but after 1 month, 2 months, 3 months, I can see even some granules when I blow the nose. I blow the nose, I can see some granules. And these granules are coming from the ostium. That means that the particles are smaller than the opening, and they can go through the ostium, and the patient after 2 months, 3 months tells you, doctor, some granules, is that normal? Come to the office, check, and do a clinical evaluation. Ask the patient, do you have symptoms? Don't have symptoms? Do you feel bad taste? Run a CBCT, blah, 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 blah. And you could say to the patient, it's completely normal. Sooner or later, it will end up. If you start having symptoms, we can do everything. Team up with a knowledgeable ENT, and always think that the cost of an ENT evaluation is around 150 euros, 250 euros, more or less here in Italy. How much do you charge for a sinus lift, 3 implants and a prosthetic? More than 200 euros. Most probably, in percentage, 200 euros with the average cost in here, in Italy, is not even 1% of the total treatment. So if you have doubts and you trust somebody, pay for the consultation. It will be 1.5, 1.6% of the total treatment that you charge to the patient. But you can solve a lot of problems. You do not panic. You are not worried. You are not concerned because you know physiology. You know how the sinus works. You know that you should refer the patient before the surgery in some cases. You should not refer the patient. You should send the patient. You should not send the patient. In 1 hour, I try to condensate 30 years of experience in sinus lift, working very close with radiologists and very close to ENT guys. If you want to do everything by yourself, the poor patient has unnecessary surgeries due to what? Lack of knowledge. Very simple and very straightforward.